to introduce our next speaker, Dr. Gregory Pugh. Dr. Pugh is a geriatric medicine physician specializing in dementia and cognitive disorders at Norton Neuroscience Institute Memory Center. He has over 25 years of experience evaluating and managing dementia patients. Welcome, Dr. Pugh.
Very good. All right, thank you. Thanks, Foy. I'm going to talk about vascular contributions to cognitive impairment. I have no disclosures to report. Some of the objectives that we'd like to cover today are to understand some of the various forms of vascular cognitive impairment. Vascular cognitive impairment is not one disorder. It's really a very heterogeneous set of conditions. Identify some common cerebrovascular changes that may contribute to vascular cognitive impairment, and help you identify some of the cognitive and other clinical manifestations that may suggest vascular cognitive impairment, in particular due to cerebral small vessel disease, which really is the most important and prevalent form of vascular cognitive impairment. So the notion that cerebrovascular disease could cause or contribute to dementia is not a new one. In fact, in 1692, Thomas Willis first reported cases of what we would now think of as vascular dementia post-apoplexy or post-stroke, and wrote then that in many, stupidity has accompanied the palsy or has gone before the apoplexy. And historically, vascular dementia has been synonymous with multi-infarct dementia, but that's really an outdated concept at this point, and we'll discuss that in more detail. The idea was a person would have a stroke, they would suffer cognitive decline, and they would suffer another stroke and sort of have a classic stepwise decline until they eventually would have so much decline that they would lose their independence and receive a diagnosis of vascular dementia. And pathological studies suggested that anywhere from 50 to 100 cc's of tissue loss would ultimately translate into dementia. Again, this really seems to be a very outdated construct at this point. And this graph sort of represents that classic stepwise progression in multi-infarct dementia that we're sort of all taught in medical school. The current thinking these days is that, and really a preferred term, is that we refer to this as vascular cognitive impairment. Not just vascular dementia, because we think of cognitive impairment nowadays, not just in terms of dementia, but the construct of mild cognitive impairment. And vascular cognitive impairment allows us to think about patients who have cognitive impairment that quite hasn't reached the threshold of dementia, but may have an underlying vascular etiology. So it's really an umbrella term that refers to cognitive impairment secondary to vascular brain injury, really from a large multitude of possible mechanisms. And it includes both mild cognitive impairment due to vascular brain injury and those that have vascular dementia. The true epidemiology of vascular dementia is very, very difficult to determine, and there is no truly agreed upon neuropathological criteria for vascular dementia, but the best estimates from neuropathological experts suggest that it is relatively rare. Pure vascular dementia probably accounts for only about 10% of all vascular or of all dementia cases. There may be some worldwide differences in the epidemiology where in Asian countries there may be a slightly higher prevalence, but it's not particularly common under close scrutiny at neuropathology. And in fact, it usually tends to occur with, co-occur with neurodegenerative pathologies. And so this just represents the fact that vascular cognitive impairment is an umbrella term that includes cognitive impairment due to all kinds of different vascular etiologies. So one could have multi-infarct dementia. One could have cognitive impairment due to brain hemorrhage. One could have cognitive impairment or dementia after a stroke. One could have cognitive impairment or dementia due to subcortical small vessel disease, which we'll see later actually is the most common form of vascular cognitive impairment. There is the notion of what's called strategic infarct vascular dementia or vascular cognitive impairment. We'll talk a little bit about that. And then probably the most common scenario is actually mixed pathologies with both vascular and neurodegenerative components. There's been some work to try and standardize the terminology because it just has been so much of a mess in terms of clinical descriptions and standardization. And this is one attempt to standardize formal descriptive terminology. So first we have the umbrella term vascular cognitive impairment, and then similar to DSM-4 criteria between minor and major neurocognitive disorder, we have mild vascular cognitive impairment, which would again translate into sort of the equivalent of mild cognitive impairment, where there is objective evidence of cognitive decline, but a person is essentially still independent, and major vascular cognitive impairment, where there is objective evidence of cognitive decline that's starting to impair in activities of daily living. And we further break that down into post-stroke dementia, where the decline occurs within 6 months of a clinically overt stroke, subcortical ischemic vascular dementia, which is related to small vessel disease, which includes a variety of different findings, lacunar infarcts and white matter disease. The classic multi-infarct dementia, which involves multiple cortical infarcts, and then mixed dementias where there is vascular contributions, and then any one of the various neurodegenerative diseases, such as Alzheimer's disease, Lewy body disease, frontotemporal dementia, etc. Just to remind you, MRI in terms of the evaluation of dementia, different sequences provide different information. The T1 images are most useful in terms of assessing atrophy patterns, in particular regional atrophy, hippocampal volumes. Andrew spoke about some of the atypical dementia syndromes where, for example, parietal atrophy might be very prominent, or frontal atrophy. The T2 weighted images, particularly FLAIR, is very useful looking at white matter alterations. And then the T2 star gradient echo or susceptibility weighted images are really important for looking at blood products. And one can imagine that there can be all kinds of different mechanisms in terms of how cerebrovascular disease could contribute to cognitive impairment. Various vascular risk factors, genetic factors, age, that there are genetic small vessel diseases such as CADASIL and CARASIL. One can have recurrent hypotensive episodes, partial vessel occlusion. Cerebrovascular disease can disrupt the blood-brain barrier. One can have small vessel disease, infarcts, white matter disease, strategic infarcts, microbleeds, cortical infarcts. It's not as well appreciated, but cerebrovascular disease leads to brain atrophy as well, which may further influence cognition. So really a wide range of different mechanisms in terms of how cerebrovascular disease in general can influence thinking. What's not as well appreciated by I think a lot of folks outside the dementia field is that very, very tiny infarcts often can have very dramatic effects on cognition. And there is this phenomena called strategic infarct dementia. And tiny infarcts in key strategic areas can result in essentially acute dementia. In some of the areas that are particularly relevant relate in particular to small vessel disease. So for example, lacunar disease, lacunar infarcts in the thalamus, the corpus callosum, the caudate, occasionally the internal capsule, or the left angular gyrus often can result in very, very acute cognitive deficits that may recover to some extent, but may frankly leave some patients with vascular dementia, and this is so-called strategic infarct dementia. So sometimes very, very tiny infarcts where people may recover very nicely from any sort of motor or other disability can result in fairly profound cognitive dysfunction. And one of the things that tends to get neglected after stroke is the impact on cognition. Lots of studies suggest that there's a lot more cognitive impairment post-stroke than is realized. And some studies suggest that even instruments like MoCA are not great at capturing the totality of cognitive dysfunction after stroke. This is just an example of what would be consistent with strategic infarct dementia with two small, tiny lacunes in the thalamus. But getting back to cerebral small vessel disease, this really is the most important of all the vascular contributions to cognitive impairment and dementia. And cerebral small vessel disease really has its greatest impact on age-related cognitive, behavioral, and gait decline. And this usually occurs in the absence of any overt or symptomatic clinical stroke. And small vessel disease comes in a variety of flavors. Most of it is due to arterial sclerosis or hypertensive arteriopathy. Cerebral amyloid angiopathy is a common cause of small vessel disease. Like I mentioned, there are some hereditary, less common forms of small vessel disease, and then occasionally some inflammatory forms. But for the most part, in our older populations with cognitive impairment, hypertensive arteriopathy and cerebral amyloid angiopathy are what we are seeing in terms of their contribution to cognitive dysfunction. Some of the most important contributions in terms of small vessel disease and their impact on cognition were made more than 125 years ago. And to be frank, there hasn't been a lot of progress since then. Otto Binswanger in 1894 described a clinical and neuropathological condition that he called encephalitis corticalis chronica progressiva. And that condition would ultimately be named after him, Binswanger's disease, which you may have heard of in medical school, where there's profound white matter changes due to lipohyalinosis, arterial sclerosis, leading to a subcortical vascular dementia. Similar back in the 1800s, early 1900s, in this case, French neurologists described conditions that we now also know are manifestations of small vessel disease and similarly associated with vascular cognitive impairment. Maxime Durand-Ferdal described diffusely dilated perivascular spaces in the basal ganglia, these dilated Virchow-Robin spaces that are referred to as état criblé or a sieve-like state in the deep basal ganglia. This is very, very strongly correlated with hypertension and arterial sclerotic changes and has a strong correlation with cognitive dysfunction. The French neurologist Pierre Marie described multiple lacunar infarcts in the basal ganglia, condition that they referred to as état lacunaire, and again associated with vascular cognitive impairment. So these small vessel changes, small vessel disease changes have long been known to be associated with various forms of cognitive dysfunction. Small vessel disease really, radiographically, there's a multitude of different findings. It's all small vessel disease, but it can manifest itself different ways radiographically. So, for example, obviously some people may present symptomatically, and one may see a diffusion-weighted abnormality, a recent small subcortical infarct. Occasionally, and this happens when people are scanned for other reasons. Occasionally, some people do, about 1%, I think, of MRI scans. People are found to have an incidental diffusion-weighted positive lesion, which usually is due to small vessel disease. Certainly, people, as they get older, many of them have are found to have lacunar disease, that in the absence of any prior history of known stroke. Increasingly, it's recognized as difficult to see on 1.5 and even 3T scanners, but increasingly it's recognized that cortical microinfarcts are a common finding. And at autopsy studies, these things are incredibly common and seem to be increasingly recognized as a contribution to vascular cognitive impairment. White matter disease is almost ubiquitous with aging and generally felt to represent small vessel disease and ischemia in the majority of cases. Microbleeds, again, quite common, particularly in patients with cerebral amyloid angiopathy and Alzheimer's disease. Cortical superficial siderosis, a very strong indicator of cerebral amyloid angiopathy. And then increasingly recognized as a manifestation of small vessel disease are these dilated perivascular spaces. Cerebral small vessel disease is highly prevalent, and any of you who've ordered MRI scans will know that based on the reports that we see in all these older individuals. And these are just estimates of different kinds of radiographic manifestations of small vessel disease in various population studies. In particular, with the white matter hyperintensities, this refers to the most severe degree of white matter hyperintensity, so-called physicus grade 3, the most severe. So for example, dilated perivascular spaces are extremely common, and even cerebral microbleeds are very common in population-based epidemiologic studies, as are silent lacunes. It's all of it is a manifestation of small vessel disease. And I try to explain that to patients when we review these scans. So this picture represents the blood supply to the deep parts of the brain. And again, these are all the small blood vessels that can be affected by these conditions. And again, in particular, hypertension tends to affect the deep perforators that supply the white matter in the basal ganglia. This tends to cause these white matter hyperintensities that we see in the basal ganglia. It often leads to lacunes or these dilated perivascular spaces. And then these cortical leptomeningeal arterioles and arteries are preferentially affected by cerebral amyloid angiopathy. So it's a very vulnerable system to both hypertension and amyloid deposition. Cerebral amyloid angiopathy is increasingly important, particularly in the era of anti-amyloid therapies. And clinically, it is diagnosed now by the Boston 2.0 criteria. The Boston criteria have gone through a number of iterations, but at the moment, clinically, it's diagnosed by applying these criteria only to people who have one of these clinical manifestations, either a prior history of intracranial hemorrhage or a history of convexity subarachnoid hemorrhage, transient focal neurological episodes, or so-called amyloid spells, are those that are in memory clinics and present with cognitive decline or dementia. The criteria are applied to patients who are over age 50 and who essentially on MRI, one can come to a diagnosis of probable cerebral amyloid angiopathy if they have two or more lobar hemorrhagic radiographic features, which could include in any combination cerebral microbleeds, evidence of intracranial hemorrhage, a foci of cortical superficial siderosis, subarachnoid hemorrhage, or any combination of the two. Or one can make a presumptive diagnosis of probable CAA if they have one hemorrhagic feature, and then unique to the most recent criteria, these 2.0 criteria, are these white matter additions, which include these dilated perivascular spaces in the centrum semiovalle there, where if there are more than 20 of these dilated perivascular spaces, or there are these white matter hyperintensities in what's referred to as a multi-spot pattern, where there are discrete sort of spot-like white matter hyperintensities in a number greater than 10. So one hemorrhagic feature or plus one of these white matter features that would meet the criteria in a patient who has these clinical symptoms that would meet the criteria for probable CAA. And then possible CAA would have just one lobar hemorrhagic feature or just one of these white matter features. It's important that they have no deep hemorrhagic or features because, again, the main distinction is that deep microbleeds, for example, really are much more closely linked to hypertensive arteriolopathy and lobar hemorrhages, much more closely linked to cerebral amyloid angiopathy. So these are the criteria that are currently used from a clinical radiographic standpoint to try and diagnose cerebral amyloid angiopathy in life, realizing it's really a pathological diagnosis. And the criteria are fair. They're pretty good with an 80% sensitivity, 82% specificity. However, the criteria are much more sensitive in people who present with hemorrhagic presentations like intracranial hemorrhage. They're probably not as sensitive in people who are in memory clinics as opposed to people presenting with hemorrhage. And recall that these criteria were validated in people that had these clinical presentations. So people who are asymptomatic or who have none of these presentations, it's not clear how well these criteria perform. It's estimated that patients with Alzheimer's disease, in fact, probably as many as 80% or more have amyloid angiopathy at autopsy, regardless of whether they meet these criteria. Subcortical cerebrovascular disease does seem to be the most common subtype of vascular dementia, and multiple neuropathological series across various age groups have provided confirmation of that. So this graph shows various autopsy studies at different age groups, looking at different subtypes of vascular dementia, comparing multi-infarct dementia versus subcortical arteriosclerotic encephalopathy or small vessel dementia, strategic infarct dementia, which we talked about, and then amyloid angiopathy. And really across all age groups, small vessel disease was the most common subtype of vascular dementia. And in addition to dementia, small vessel disease really has some additional features that are unique to it. And it's not unusual. I think Dr. Cooper mentioned a bit that small vessel disease and vascular dementia, secondary to that, tends to have a clinical presentation fairly typical with frontal executive dysfunction, cognitive slowing, attentional dysfunction in particular, also gait disorders, neurobehavioral symptoms, in particular apathy, some depression is not unusual, as are urinary symptoms such as urinary urgency, frequency, and occasionally urge incontinence. So there are some other non-cognitive symptoms that may tip you off to the fact that small vessel disease could be responsible for some of the symptoms. And realize that small vessel disease can have a very slow, insidious course. So again, getting away from the notion that a stepwise presentation is always seen in vascular dementia. In fact, the majority of cases due to small vessel disease are slow and insidious. And the addition of these other features, apathy, gait problems, urinary dysfunction, falls, balance, these are things that can clue you in obviously in addition to the neuroimaging findings. Cerebral hypoperfusion itself is also a mechanism that can lead to cognitive decline. So if you look at some of these conditions, they all seem to be associated with cognitive dysfunction. So Atrial fibrillation and other arrhythmias have been associated with cognitive impairment, ischemic heart disease, carotid stenosis, heart failure, chronic lung disease, sleep apnea. So again, chronic hyperperfusion through a variety of means also seems to lead to cognitive impairment. And addressing those factors may result in some improvement in some patients. This is just an example of a variety of severity of different white matter lesions, and the most common rating scale is the Fazekas scale. And probably as we age, Fazekas grade 1 is probably normal. It's not very likely at that stage that would contribute much to cognitive dysfunction nor functional decline, to be honest. I think you have to be cautious about overcalling the importance of that degree of white matter change. And certainly when you get to grade 2 and grade 3, there are real implications in terms of both its potential impact on cognition, as well as its impact on potential disability, risk of stroke, and even death. When you get to particularly grade 2 and certainly grade 3, this is not a benign finding, and it's really associated with very poor outcomes. The most important study that looked at this was a study called the Leukoariosis and Disability Study. It was probably about 10 years old or more now. And this was a study that looked at incident disability and death in people with white matter disease based on the severity of their white matter disease, and stratified people simply based on their Fazekas scale, and looked at the risk of progressing to disability or death over a period of just 3 years. And you see that people that had the most severe white matter disease, the line in green, had a very, very high risk, even just over a period of 3 years, of progressing to either death or disability. And when you further characterize that by the volume of white matter disease, those that had the highest volume of white matter disease had very rapid decline in both function and risk of death. So this white matter disease, it's important not to overcall it when it's extremely mild, but it's important to take it seriously when it's significant, because outcomes are not good. So the clinical manifestations, again, of cerebral small vessel disease in terms of its cognitive impact, again, it does tend to affect executive function. It tends to result in slow processing speed, troubles with working memory and aspects of attention. In terms of memory, it tends to cause a retrieval or a frontal subcortical memory problem, as opposed to an amnestic problem. And what does that mean? It means that people tend to improve with recognition paradigms or multiple choice. So they can encode information, but they seem to have difficulty retrieving it. So when you give them a paradigm where you give them choices or force them to recognize or discriminate what they were learned, they generally perform better, as opposed to an amnestic disorder due to hippocampal damage, Alzheimer's type medial temporal lobe problems. And I sort of think of this, and I try and explain it to patients, as patients with frontal subcortical memory problems might be thought of as being more forgetful, and the Alzheimer's patients are really amnestic. There is a difference between being forgetful and being amnestic. And these small vessel changes very often are associated with other neurobehavioral symptoms, in particular apathy or depression, occasionally a pseudobulbar type affect. Gait disorders are increasingly recognized as a sequelae of small vessel disease, vascular Parkinsonism, or pseudo-Parkinsonism, really. Balance disorders, falls, urinary symptoms, such as frequency and urge incontinence, are common. So it's really sort of a whole body condition, so to speak. And this graph is sort of designed to explain that. And these are people, for the most part, who haven't had a clinical history of stroke. So there are impacts on cognition, which we mentioned, impacts on mood, sometimes some changes in personality or fatigue, urinary symptoms, gait and balance problems, occasionally other neurological soft signs and symptoms, swallowing, speech troubles, occasionally so some subtle neurological findings on neuro exam in the absence of a known clinical stroke. This slide sort of summarizes the impact of different kinds of small vessel changes on cognition. So white matter hyperintensities might impact executive function, processing speed, aspects of episodic memory. Atrophy tends to affect global cognition. Lacunar disease, executive function and memory, microbleeds, executive function, and some aspects of spatial and perceptual abilities. Dilated perivascular spaces seem to be associated with impaired processing speed and visual motor speed. So really, all these different manifestations, and these again are all manifestations of small vessel disease, can have wide-ranging impacts on cognition. There's been a lot of work on biomarkers for Alzheimer's disease, but other than radiology and radiographic markers, we don't have any biomarkers for small vessel disease. And Dr. Cooper mentioned earlier, one of the challenges, why do some people have a lot of vascular change on their MRI and not many symptoms, and others are profoundly affected? We don't know the answers to all of that, but there is a growing interest in looking at biomarkers for small vessel disease that is most closely associated with vascular cognitive impairment. And there is a national consortium looking at some of these biomarkers, trying to predict what biomarkers in small vessel disease seem to best be correlated with all the cognitive impairment that we've discussed. So there are many promising ones, including plasma-based biomarkers that seem to be most closely linked to the development of dementia and cognitive impairment that hopefully we'll be able to measure in the future. So what about the management of vascular cognitive impairment and vascular dementia? So multiple meta-analysis have shown small but significant benefits of cholinesterase inhibitors, donepezil, galantamine, rivastigmine, and NMDA receptor antagonist memantine for cognitive dysfunction in vascular cognitive impairment. The studies are generally very limited in duration, and most of the studies have not reported significant benefits on function or behavior. Many people in clinical experience suggest that memantine often does have some favorable effects, particularly on apathy in vascular dementia. It often can sort of get people going and have some favorable effects on passivity and apathy in vascular dementia. And also, given the high likelihood of mixed dementia, again, it's estimated probably, like we mentioned, probably less than 10% of all dementia is pure vascular. A trial of cholinesterase inhibitors and memantine may be worth considering since there's such a high likelihood of mixed dementias. Internationally, the international experience is that donepezil is actually approved for vascular dementia in some countries, New Zealand, India, Romania, South Korea, Thailand, and memantine is approved by regulatory authorities for vascular dementia in Argentina, Brazil, Mexico. So mixed dementia, again, is really the most common scenario here, and really, frankly, in older individuals is the norm. Pathology studies confirm this. This is one longitudinal study with neuropathologic confirmation, the religious order study. And in this study, amongst people who were clinically followed for many years and clinically diagnosed with probable Alzheimer's dementia, 447 patients who were clinically diagnosed with Alzheimer's disease who came to autopsy, it was found that a vascular contribution of some sort, either small vessel disease or cortical infarcts or white matter disease, some vascular contribution was found in at least 87% of the cases. And in fact, pure Alzheimer's disease was quite rare, accounting only for 3% of all cases. And this would be sort of a typical scenario here. Somebody with very severe white matter disease, probably a lacune in the centrum semiovale on the left up there, who also has very profound hippocampal atrophy on the left, probably with a medial temporal atrophy rating score of 4 on the left, probably 3 on the right. So this would be fairly typical of someone with a mixed vascular Alzheimer's dementia. And there'd be no reason not to treat this person with a cholinesterase inhibitor or memantine if indicated. The other important point to recognize is that cerebrovascular disease can, if you will, unmask Alzheimer's pathology. So there can be, if you will, synergism between vascular disease and Alzheimer's pathology. And several studies have looked at this. The Rush Memory and Aging Study, in this study, 148 brain donations with longitudinal neuropsychological assessment were examined. And after controlling for cortical infarcts and the degree of Alzheimer's pathology, small subcortical infarcts increased the odds of dementia almost fourfold. So the influence of little tiny small subcortical infarcts really played a large role in terms of how Alzheimer's disease might express itself. And then a very famous study, the Nun study, showed that patients, or subjects, I should say, who had lacunar infarcts in the basal ganglia, the thalamus, or the deep white matter, again, these sort of key structures that regulate frontal subcortical aspects of cognition, had a very high prevalence of dementia with an odds ratio greater than 20 compared to those who had no infarcts. And it seemed that those that had infarcts in these deep structures that are so vulnerable to, in particular, hypertensive arteriopathy, that it took much less, if you will, concentration of Alzheimer's pathology to result in dementia. So you can imagine if you have two people who have the same level of same concentration of Alzheimer's pathology, they are not clinically demented yet. One of them develops a couple of silent lacunes in those deep areas related to hypertension. Now, all of a sudden, that person has a 20-fold greater risk of expressing clinical dementia. So one of the things that is not known is what to do about all this, in particular white matter disease. We see it all the time on these brain scans. And what do we do about it? There's really little evidence to guide clinicians on how to manage not just white matter disease that we see on brain scans, but even these covert lacunar strokes that we have to explain to patients all the time. The European Stroke Organization a couple of years ago sat down to try and review the world's evidence on this and come up with some guidelines despite very limited science in terms of answers. They did come up with a few statements here and basically said that at the moment there is insufficient evidence to advocate for lowering blood pressure any lower than standard targets, although lowering blood pressure to a target less than 120 systolic did seem to result in a slower increase in white matter hyperintensity volume and decrease the risk of mild cognitive impairment and dementia. And that's essentially the SPRINT MIND trial data. But they didn't make a strong statement that other than targeting conventional blood pressure targets, that there was profound evidence for that. They did make actually a very firm statement that they suggested against the use of antiplatelet drugs in subjects who had covert small vessel disease defined by white matter changes or asymptomatic lacunar infarcts when no other clinical indications existed, meaning that There was no history of symptomatic stroke, no history of coronary heart disease, based on the fact that the current available evidence suggested that it may be harmful in patients over 70 years of age. So again, the primary prevention data for aspirin in people over 70 is not favorable given the risk of gastrointestinal symptoms. And the best data at the moment suggests not starting aspirin for covert cerebrovascular disease that's found incidentally on MRI scan. They recommended that lipid lowering could be considered, though the strategy is not proven, and that many questions still remain unanswered, such as should aspirin be given to patients with a covert lacune found incidentally. We just don't have any answers for that. One of the things that is somewhat interesting and a bit discouraging, to say the least, is some of these areas of uncertainty. Studies suggest that in fact, traditional cardiovascular risk factors, we see these white matter changes and we say, well, this is all related to your age and your hypertension and smoking and diabetes. But it turns out only about 16% of the variance in terms of white matter disease is accounted for by traditional cardiovascular risk factors. There's a very small amount that is accounted for by traditional cardiovascular risk factors. And blood pressure alone accounts only for about 10%. So at the end of the day, there's about 60% of white matter hyperintensity volume that goes unexplained. So blood pressure is by far and away the most important. Age is important. But despite that, a lot remains to be unexplained, and we do see people who have a significant amount of white matter changes that likely contribute to their cognitive dysfunction, who don't have a lifelong history of hypertension or diabetes or smoking, and it's difficult to explain why did they develop that. But studies give us some answers that there's a lot we don't quite understand. And the other point that is somewhat discouraging is that in clinical trials looking at secondary stroke prevention, even with very, very aggressive secondary stroke prevention measures, despite applying aggressive guideline measures, that progression of white matter hyperintensities has been described in that setting as well. So there are genetic influences, other inflammatory influences, lots of things that are not quite understood. So in reality, there hasn't been lots of advances since the time of Binswanger and his colleagues back more than 100 years ago. So in summary, cerebrovascular disease, particularly small vessel disease, is a major contributor to cognitive impairment and disability in late life. Cerebrovascular small vessel disease can be identified through a variety of radiographic findings that carry an increased risk of cognitive impairment and poor outcomes. Vascular dementia in isolation is probably relatively rare, and mixed dementias are really more typical. The management of cognitive impairment in vascular dementia or mixed dementia ultimately probably is similar to Alzheimer's disease. And other than lifestyle measures and management of hypertension, the best practices for the management of cerebral small vessel disease still remain to be elucidated. We don't quite know exactly what the best practices are, other than healthy living, diet, hypertension management, cardiovascular risk factors that we all advise for the majority of patients, which also promote healthy cognitive aging.
All righty. Thank you very much, Dr. Pugh.